Good evening and welcome to one and all. My name is Shashank from Clanet, the destination session assistant from a seamless experience. And Clanet is India's most trusted and widely used digitech platform for multiple enriching services inclusive for doctors. Clanet is very proud to be a digital partner for this event organized by India Academy of Pediatric Gujarat. And the topic of today's session is case discussion on delayed development. Let's begin today's session, for which I would like to invite to Dr. Neha Patel to take over the follow the event. Over
Thank
to you, ma'am.
Thank you, Clarinet, and thank you, Shashank, for giving this platform. So I welcome all of you to our e-Gurukul Pathshala, the PG Clinic. Today we have a discussion on delayed development, a child with the delayed development. And for this, we have a presenter, Dr. Kritika Negi. She is a resident from Sri Guru Ram Rai Institute of Medical and Health Science, Dehradun. I also welcome her mentor, Dr. Shruti Kumar. She is an assistant professor in the Department of Pediatrics of the institute, same institute, Sri Guru Ram Rai Institute of Medical and Health Science at Dehradun. I welcome our two esteemed experts, Dr. Shiji Chalipat. So Dr. Shiji, she has done her MBBS from the GMC Thrissur and MD from BJMC Pune, has done her fellowship in the pediatric neurology from Thiruvananthapuram, and she was visiting fellow in the neuromuscular disorder at Oxford, UK. She is at present professor and pediatric neurologist with in charge of pediatric neurology fellowship program at Dr. D.Y. Patil Medical College, Pimpri, Pune. She has 24 publications in various national and international journals, and her area of interest is neuromuscular disorder, developmental neurology, neonatal neurology, and neuroimmunology. Welcome, Dr. Shiji.
Thank you, Dr. Nehal.
We also have our next esteemed expert, Dr. Deepika Jain. She is a developmental pediatrician. She has done her MD, DPED, DNB, and PG DDN. She is at present working as a consultant pediatric developmental pediatrician at Shishu Child Development and Early Intervention Center. She is also a visiting consultant at LG Government Hospital, AMC Met, and now Narendra Modi Medical College. She has specialty in high-risk developmental clinic in NICUs, and she is a non-affiliated member of Institutional Ethics Committee at IIT Gandhinagar. She has many paper and poster presentation in various international conferences, and she is principal co-investigator in genetics in autism research project. She is master trainer of IAP race module for the high-risk newborn. Welcome, Dr. Deepika.
Yeah, thank you, Dr. Nehal.
So today we have our mentor guru, Dr. Baldev sir, with us to guide us in this case as the case progresses. And I also see Dr. Aarti Kinikar, madam, here with us.
Good evening, Dr. Nehal.
Welcome, ma'am. So we are going ahead. So Baldev sir, now the platform is all yours.
Good evening, friends. Welcome to this our Saturday PG Clinic. It's nice to see the presenter from the Dehradun, very, I will say, different places. And I'm sure that credit goes to mentor Dr. Shruti Kumar. I'm sure that this will be the very interesting discussion for the postgraduate MD students. I think they must be familiar that this is very common question. Maybe the theory question in the form of the approach to a child presented with delayed development at different ages, they may put the question, or even in this short case, long case, the discussion is going to be there. And nowadays, you know that this is a very important issue for any general pediatrician and so for the specialized person. So I'm sure that it is going to be a very interesting discussion, and I request all the postgraduates, those who are present on the screen, that please keep your video on and participate in the discussion very freely. First, I would like to identify the students so that we can interact appropriately. I think mentor, madam, I think you must be familiar with your postgraduates. Can you just introduce them, and please keep your video on, all the students.
So
I can
Dr. Dhaval,
okay.
Dr. Ayush, Harish, Dr. Aarti, Dr. Shahid, Dr. Shubham. These all are residents.
Postgraduates. Okay.
Yes.
So please keep your video on. Already what Madam mentioned the name, yes, Dr. Aarti. I know that probably familiar face. In the past also she has participated.
Good evening, sir.
Yeah, good evening. Yes, Dr. Shubham. I think these faces are familiar, but somehow they are remaining away. Hiding themselves, probably must be the shy personality, but you know that in the exam we'll have to speak, we'll have to come forward. This is the purpose that I wish that the students should be there. Yes. Kritika, I will request you to start your history part,
Yes,
sharing your PPT, whatever way you have managed.
yes.
So Shashank, have you received the PPT?
Yes, ma'am.
Please share.
Prashak, I think if Kritika is not able to manage, you can share and she will present and then she will say next slide like that.
Sure, ma'am. Sure, sir. Once you said me next slide, I will just do that. Just give me 1 second.
Okay.
So Kritika, you start.
Okay. A very good evening to everyone. Myself, Dr. Kritika Negi. I'm a junior resident in the Department of Pediatrics at the SGRR Medical College, Dehradun. And I'm here to present a case on your developmental delayed play. So can we go on to the next slide? So we'll start with the patient profile. Patient XYZ, who is a 3 years, 7 months male patient, hailing from Uttarkashi, Uttarakhand, Hindu by religion, whose informant is mother, and the history seems to be reliable. Next slide. He presented with the chief complaint of delayed achievement of milestones as noticed by the mother since 11 months of age. Next slide. Starting with the HOPI. 3 years, 7 months male child who is second by birth order, born out of a non-consanguineous marriage. So I'll be starting with the birth history. So the mother was a 23-year-old at the time of conception, a second gravida, second para, and this baby was conceived out of a spontaneous conception. Her first baby is a 7-year-old male child. Second pregnancy was aborted by MTP at around 6 weeks of gestation. This pregnancy was confirmed by a UPT and she was a book case throughout her pregnancy. Mother had 6 to 8 antenatal visits during her entire pregnancy and she took periconceptional iron and folic acid supplementation. Next slide. Now the antenatal course. During the first semester, mother took iron and folic acid supplementation starting after confirmation of her pregnancy. There were no complications such as excessive vomiting, fever, skin rash, bleeding PV, or any UTI. There is no history of any radiation exposure or any unknown drug intake. And her dating scan was in the first trimester and a twin gestation was confirmed. Next slide, please. Second trimester history. Nutritional supplements were added here and quickening was felt at 5 months. There is no history of any pregnancy-induced hypertension, gestational diabetes, or any thyroid disorder. A anomaly scan was done, which was documented to be normal. Then third trimester, nutritional supplements were continued, and there was no history of any polyhydramnios or oligohydramnios, any history of foul-smelling liquor, UTI in mother, or any fever episodes in the mother, no history of PIH or any pedal edema. Then the US during the third trimester showed that one of the twins had demise, and the mother was taken for an emergency cesarean section at around 30 weeks of gestation. Next slide. Then the natal history. This delivery was an institutional delivery. Mode of delivery was an emergency cesarean section because one of the twins had demised. There was no history of an meconium stained liver. It was a preterm 30-weeker delivery. This was the first twin who was a male child with a birth weight of 1.4 kg, which was appropriate for gestational age. The baby did not die immediately after birth. Apgar and resuscitation details were not available. And according to the mother, the baby was immediately shifted to NICU after resuscitation. Then NICU stay. Baby was transferred to NICU, where he was admitted for around 2 months. According to mother, during this stay, the baby was kept on oxygen therapy, oxygen support for around 10 days. There's no history of any mechanical ventilatory support as per the mother. The baby was tube fed during hospital stay, which was started on 3rd day of life, and EBM was given. Then KS feeds were started from around 10th day of life. There is no history of any seizures or hypoglycemia episode during the hospital or an ICU stay as told by the mother. Mother received baby on 10th day of life in the PNC, but the baby was shifted back to an ICU in view of jaundice, as the mother and baby were RH incompatible. And also mother told that there was some history of infection as told by the NICU staff to her. The baby was kept in NICU till the time of discharge, which was around 2 months. There was no history of any blood product transfusion during the NICU stay. Baby was discharged at 2 months of age. There is no history of any excessive irritability, abnormal body movements, lethargy, decreased limb movement given by the mother at the time of discharge. And the weight at discharge was 1.4 kg at 38 corrected gestation age. Breastfeeding was tried but could not be established due to poor latching, but the baby was accepting KS feeds well, as told by the mother. He had good sucking and KS feeds were continued. Baby was started on formula feeds via spoon at 4 months of age with correct dilution. Now coming to developmental history. There was partial head holding present at 7 months of corrected age, complete neck holding at 9 months. Rollover was present at 12 months.
I think Kritika, for a while, can you just stop sharing? I think Shashank can do it.
Yes.
The point is, I think before you go for this developmental history,
Yes, sir.
let us recapitulate whatever you have described.
Yes.
Otherwise, it will happen so that we'll forget what you have spoken. I think a question to the other students. First, always the students and experts will be last to add their real expert comments. And the students that whatever she has described, any comment from other students? Suppose something she had missed, or if you want some clarification, or whatever thoughts are there with this description. Anybody? Yes, Dr. Dhaval, Dr. Aarti, any point from your side?
Sir, till PNC shifting history was proper. After reshifting to the NICU for RH incompatibility due to hyperbilirubinemia, was there any event or any conversion or any posturing or significant kernicterus like sign was there or not? Was not cleared.
Yes, Dr. Kritika, can you clarify it?
Sir, as per the mother, there was no history. She's not giving any history of any abnormal movements, abnormal posturing, lethargy, or decreased feed intake, or any history of any blood product transfusion after the episode of jaundice.
What treatment was required for this RH incompatibility? Just phototherapy or anything else?
Yes, sir, just phototherapy.
Okay. Any idea regarding the bilirubin levels? Probably parents may not be knowing.
No, sir.
Okay. Okay, but I think this is one of the points. Of course, whatever the information is available, we should go in details. Aarti, agreed. Anything else? Dr. Dhaval?
Any congenital screening was done at that time, was not during 10 days of NICU stay to look for thyroid and other things, as the child was presented at 10th day of life with RH incompatibility.
Okay, Kritika?
The mother had no details of any specific congenital screening tests. She just said she was regular for the ANC visits, and all the tests and reports that were provided to her were normal until this third trimester when one IUD, one of the twins were IUD.
Okay, I think Dr. Aarti, this is not the uncommon story in our daily practice, what Dr. Kritika described. I think on the contrary, why now it has become our routine, regular practice of getting such babies. And I think in that case, suppose if you were the treating person, what specific high risk you have noted in this patient where development is likely to be affected? Can you enumerate the points in particular patient? And I think it is very important as a treating person that we should find out that what are the high risk issues in this particular case can likely even create the problem with the development. And so that probably at the time of discharge even, you can share, you can counsel to the parents so that on follow-up, probably it becomes easy or at least mentally they are prepared or ready that these issues were expected. Dr. Aarti, can you enumerate the issues, high risk issues in this baby? Or
So
specifically
baby
for the development? Yes, Aarti.
Sir, first of all, after admission, high risk baby, we'll do the thoroughly examination of the child. Is there
I think, sorry, Aarti, what I want from you, and I'm sure that this will be the very common discussion in the postgraduates, whenever such case is there, that points you should start from the antenatal point, history.
Yes.
Some issues must be there.
Yes,
Even
sir.
suppose she had mentioned directly just to sensitize, if I ask the question, she had mentioned age of the mother. Is it important for us to know?
Yes, sir.
What way?
Sir, early age or late age, then multiple pregnancies, nutritional status of the mother, dietary history plus antenatal any history of diabetes, hypertension or thyroid of the mother. Second trimester quickening feel by mother, whether the child movement and quickening were normal or abnormal according to mother.
I think now, Aarti, you can spot the points, which were, I will say in this case, indicating that the clinician should be very alert because it can create the problem with the development of the baby. And with that reference, I asked the age of the mother. You know, advanced age of the mother, suppose you are expecting that there may be some problem of even the Down syndrome or something.
Yes, sir.
Which can create the problem with the development. So illustrate one example with any and specifically identify the issues in the particular case which the Kritika has described. That this point was indicating that it can create the problem. Like that. Suppose antenatally.
Sir, early age of mother, baby can be IUGR. Then, as you already told, sir, advanced age may be Down syndrome and other syndromes also can be present.
Dr. Dhaval, can you identify these problems in this particular case?
Yes, sir. In particular this case, there is a history of IUD in antenatal period. Second thing,
sorry to interrupt you. Why you don't mention that these twins itself is always the high risk? If you have noted the twins always, because twins are going to be the preterm issues, problems. So twins pregnancy itself is high risk like that. And as you said, one already demise of the baby. So identify like that what are the points in this particular case, what she has described. Go ahead, Dr. Dhawan, please.
Yes, sir. Twin pregnancy, antenatal history of one IUD, then child deliver prematurely. So prematurity.
Yeah. So prematurity itself is issue. Yes, good.
Yes, low birth weight. As child was 1.4 kg only. Then at time of birth, child didn't cried after birth. So birth asphyxia.
Right?
Then history of RH incompatibility, NICU stay again.
Yes.
History of 10 days of oxygenation need for oxygen and all. And
Definitely.
then after at time of discharge and as she was taking history, child was still on case feeding and not on breastfeeding.
Right.
So it's also suggesting some the child is still on high risk.
Yeah, very good point. Actually, what is my idea that whenever you get such case, try to spot even that what are the risk factors in that particular. We should be mentally prepared even because we are expecting some issues. At the same time, at the time of discharge, you talk to the parents so that they are aware that these issues were there. And very nicely you have done that. There's a twin pregnancy itself. Many times when suppose somebody has taken this treatment for infertility, that is also one of the issues. So twins pregnancy, demise of one baby, preterm baby, low birth weight baby, history of some delayed cry suggesting birth asphyxia, NICU admission. During that time, RH incompatibility. She mentioned even the sepsis also, requirement of oxygen for a long time, 2 days, 10 days, 2 weeks, whatever the time she had mentioned. Fortunately, at least the ventilator support is not there. Otherwise, it becomes a even still high risk problem. So like that, in all these issues, we are expecting that the baby has survived, but still these problems can adversely affect the development of the baby. That we should note. Even one more point, anomaly scan. Many a times, suppose by chance there is any anomaly in the baby, that can also, you should note it, right? So I think these are the points which are in the history, you should note it. I think before we go further, let us take some of the points from experts also, that what we should keep in mind. Dr. Shiji, can you take it? That what are the likely some risk factors which may be in this case or otherwise, what, as I will say, as a clinician, we should keep in mind, please.
Yes, sir. Thank you, sir. Actually, you have summarized it very beautifully. In this case, starting with the previous history of some MTP done. So was it done because of what? Indication of because child had some anomaly, that fetus, or it was done unwanted pregnancy. So that was very important history. That indicates some genetic etiology. So that is one risk factor in the antenatal previous history. And second, in this case, yes, twin gestation itself is a very high risk factor, and the IUD. So what are the complications you will have if one fetus dies and the complication to the other fetus? Residents, anyone?
Ma'am, there
So
can
in twin gestation,
there could be a thromboembolic event which could lead to compromised flow to the surviving twin, which
yeah, so stroke, fetal stroke. So that is very good. And coagulopathies. So bleeds. There an arterial stroke or a bleed can happen because of coagulopathy. And finally, and third thing is asphyxia, sudden hypotension and asphyxia. So whatever it is happening is causing a brain damage. So it can be in the form of stroke, arterial or hemorrhagic. Third is birth asphyxia because of sudden hypotension. So all these three. So that is important factor, IUD of one twin. And third is, yes, preterm delivery, low birth weight, not criteria. So preterm asphyxia, birth asphyxia, NICU admission with respiratory distress. Surprisingly, 30 weeker is not ventilated and surfactant not given from the history. So, and immediately shifted to the mother's side, and then jaundice happened on delivery. So that is a bit odd, maybe. So RH incompatibility, jaundice, maybe a persistent jaundice after 10 days, and then 2 months history of it. So something is missing there. Anyway, strong risk factors, multiple risk factors for this developmental delay in this child.
Thank you, madam. I think very important point which madam highlighted, that whenever the suppose twin pregnancy and one of them in the intermittent death, that the baby who is surviving, what are the likely problems or complication? I think a very good point which we should keep in mind, that these issues may be there. Besides already everything discussed. I think one point which madam raised, that this baby was preterm, even significantly preterm. Still didn't require even this ventilator support. which is commonly probably most of the babies require, or even surfactant therapy. For that, anybody would like to make the comment? What is the likely factor which might have protected this baby from these therapies which we were not required?
Mother must have
Sir,
get steroids
antenatal
because
Okay,
antenatal steroid.
one of the points, I'm not sure. Kritika, you have the information whether mother was giving the steroids, antenatal steroids? Any idea?
She was not sure of this history. I asked her.
Okay.
Remember.
And anything else about besides that? What you can predict even may not be, I will say, evident, but yes, even suppose if you see the baby, you can even make the comment. Here, what I will make the comment that prematurity is there, but probably rather than that, IVGR must be the major issue. And you know the IVGR, even this weighted less for that maturity, that intrauterine growth restriction, somehow these babies are always at struggle, stress, and that endogenous steroid secretion are protecting them. And very specific, the complications of the prematurity, particularly the RDS and even these other issues, these babies may get some protection. So probably rather than the maturity is the problem, but may not be the significant as per its maturity. That probably might have contributed for, I will say, these complications were not in this particular case. Anyway, but I think this is a very important point which I wanted to bring to the notice to the students, that any this type of case is there with you, you should note all these issues. And these are the likely points, and they are going to affect the adversely development of the baby. So that on follow-up, you can assess it properly and you can go for further. I think before we go further, Dr. Deepika, anything from your side to add?
Yeah, you have already done most of the job. But I would like, because I'm thinking like a developmental pediatrician, one, we should never forget father's age. And second, the socioeconomic status here, because this is a young mother. She's already having a 7-year-old kid, and this is the second kid. With all the adverse factors, that becomes very important later on when we are working on the interventions for this kid.
Right.
And second is Kritika, do you have any information about the ROP screening and hearing screening for this kid, and any any postnatal sonography was done for this kid?
Postnatal USG cranium, ma'am. Mother does not remember, ma'am. She does not know any of the details that were done.
Okay. I think in this development of the history, we'll see whether she provides this information. Then I will come back to this point, Deepika, what you have raised, definitely.
Sir, this IROP also, I mean, because that also becomes very important here.
Yeah.
30 weeker only.
Right. Okay. Should we go further, Kritika? I think Shashank, can you share your PPT, and Kritika will continue.
Sure, sir.
Rajat, please close your mic when you are not speaking.
From here?
The next slide.
Next slide. Okay.
Now, developmental history. We'll start with gross motor milestones. The patient achieved partial neck holding at 7 months of corrected gestational age. Complete neck holding by 9 months. Rollover was present from 12 months onwards. And this was the point where physiotherapy was started. Then he developed sitting without support by 2 years corrected age, standing without support by 2.5 years of age. He started walking independently by 3 years age and running by 3.5 years. Currently, the patient is able to walk upstairs using support, and his DQ for gross motor is 40. Next slide, please. The next slide. Yeah, just there's this video of him walking upstairs.
It's like that only. The video's not playing actually.
I have this video on my desktop. If I could share this with you all.
Yeah, sure. I'll do one thing. I'll just stop share from my end.
Please, please.
Hmm.
Okay. Scribbling gate upstairs. Where is my screen visible to you all?
Yes, yes.
Okay. Then can we move to the next slide, please?
I think Shashank now we have to share.
Yes, I'm doing it. One moment, sir.
Yes. Fine motor. He achieved bidextrous reach by 8 months of corrected age. Unidextrous reach, which was left-handedness, was noticed by 15 months of corrected age. Pencil grasp by 2 years of age. Scribbling by 3.5 years. And he was able to make a tower of 4 blocks. This is his currently recent fine motor milestone. He is able to scribble and make a tower of 4 blocks. And the DQ here is 40. So next slide, please. I'll show this video towards the end of the milestones. Next.
Yeah,
slide.
I think you can do it then.
Yes. Language, previous one. Yes. Cooing at 3 months, monosyllables by 6 months of corrected age, and bisyllables by 9 months of age. He started responding. So, next, please. Next one. The next slide. Yes. He started responding to sound with turning his head directly towards the sound by 11 months of age. He developed 1 to 2 words with meaning by 2 years of age, 2 to 3 word sentences by 3.5 years. And he is currently able to recite poems, but not very fluently. And his DQ in the language domain is 55. Next slide. Then social milestones. He achieved social smile at 3 to 4 months of corrected age. He was able to recognize mother by 6 months of age. Stranger anxiety was present at 8 months age. He was able to play simple ball games by 15 months age. And he was able to copy parents and tasks by 2 years of age. Currently, he shares toys and has interactive play. DQ in social domain is 80. Next slide. Yes, so if I could share my screen, I'll show the video of the scribbling and the fine domain.
Okay. Did you finish this developmental history?
Yes, the developmental milestones are finished.
Okay. Anything in the history, developmental history?
So now I'll be continuing with the his past, I mean, the HOPI now, but development.
Okay. Okay.
Yes, sir.
So Shashank, you have to stop sharing, and again Kritika will show the video.
He has scribbling with his left hand. Uh, so please, could you share your screen again?
Okay.
Kritika, Kritika, you only can share your PPT if it's possible. It'll be easier.
Oh, ma'am. Actually, my presentation is I'm not able to display it completely on the screen. There is some-
Okay, fine.
Yes. The mother noticed that she faced difficulty in changing the baby's diapers as there was tightness of hip joints since 4 to 5 months of age. Also, she complained of squinting of eyes of the child that she noticed at around 5 to 6 months of age. There was weakness of the right side of the body since 15 months of age, and the child was unable to hold objects with his right hand. Then he had an episode of lower respiratory tract infection at 8 months, for which he was admitted at some hospital and was managed conservatively for 5 days and was discharged. The parents were told that the patient also had an episode of seizure at that time. However, he was not started on any anti-epileptics as told by the mother. This seizure was not witnessed by the parents. So next slide. Next slide, please. Yes. The mother noticed that the child also had an episode of abnormal body movement at home at 10 months of age, which was preceded by fever. It was a GTCS type of seizure that lasted for about 1 to 2 minutes and was self-aborted, following which he was taken to a hospital where he was started on anti-epileptic Levipil and was discharged after 3 to 4 days. Child at that time had no post-ictal deficits or any complications. Then the mother noticed that the baby had not reached milestones as compared to his elder brother at 11 months of age, for which he was brought to our center and was evaluated for developmental delay. Here, physiotherapy and occupational therapy were started. At 14 months of age, parents stopped anti-epileptic Levipil by themselves. And 1 month later, he had another episode of abnormal body movement, which was not associated with any fever episode. It was GTCS type, and the duration was 1 to 2 minutes, which was self-aborted. Following the seizure, the patient was brought to our center and he was started on anti-epileptic valproate.
Next slide.
He had another seizure episode at 3 years of age after 15 months, which following which valproate dose was readjusted and the patient has been seizure. At the time of presentation, the child had developmental delay and there was toe walking present, which was more on the right foot. Next slide. There is no history of any sleep disturbances, drooling of saliva, feeding difficulties. The child was able to chew. He did not take long time during feeding sessions. He used to take small bites and was able to eat solid foods. Was unable to self-feed properly with spoon and hence the mother feeds him. There is no history of constipation, any recurrent respiratory tract infections requiring hospitalization, no history of any abnormal odor, excessive vomiting, regression of any of the achieved milestones at any point in time, and there is no history suggestive of any sensory involvement. Next slide, please. Then treatment history. After admission, basic workup was done, including hearing and vision assessment. Occupational therapy and physiotherapy were started. Anti-epileptics were continued. Speech and language stimulation was taught, which was done at home. Now patient has been seizure-free since the past 8 months on valproate, and schooling has been started since the last 6 months, and he's in nursery standard. Next slide, please. Family history.
Okay, I think here can you just stop sharing? Shashank. But I'm afraid that people may not remember this long history. And I think this interruption is necessary. I think before we go for this, our patient, to understand the delayed development, first we should have the clear ideas, some aspects, some principles regarding the normal development, so that we can understand this delay in a better way. Who will take these some basic ideas or principles of normal development? Anybody?
So the development proceeds from cephalocaudal.
Okay, very good.
From proximal to distal.
Right.
Then disappearance of the primitive reflex is required for development of the mature reflex.
Very good. Perfectly. Anything else? Anybody else? Dr. Aarti?
So we can always compare the normal achieving development with the normal charts. And in this cell, who have achieved a little delay, early handedness, which usually should not be there.
Okay. Anybody else? Taman, would you like to add something? Normal development. And why I'm coming to this point, unless we are fully aware, probably we will not be able to interpret it properly. Just should we consider normal or abnormal? What is the abnormality? And then how you should go for further the problem of the delayed development. Therefore, I thought that this is an important aspect which every pediatrician should know. And some of the points Dr. Rajat and Dr. Aarti mentioned, yes, they are right. Any other students? I hope that so many students are there. Anybody else? I think Shahid was there.
So we can also consider major milestones. Usually we are following that at this age, these milestones should be present, but there is a range. For example, if a child is not able to walk till 15 months, then only you can tell it is delayed development.
That is also right. Good. That means you should be able to interpret it properly, not enthusiastically early or late, or at what time exactly you should say delayed. It is also important. Yes. I think first what we should know that initial period is very important from the development point of view. From conception to the birth, even the initial, many people say 5 years, but at least minimum 2 years. Because this is a very important, I will say, golden time for the baby for development point of view. And any insult during this period probably may be the major setback to the child from the development point of view. So it's very important. Suppose the baby develops meningitis in 6 months old child, or develop some, suppose, head injury or trauma, or even birth asphyxia, as all of us know. So any this type of the insult to the brain, developing brain, once it is developed, of course there will be damage, but probably from the development point of view may not be as impact will be there as it is in the developing brain. So that's very important. Second, what Rajat mentioned, that the development is always, if you look order, first baby develops this head support, then turning, then sitting, and then walking. And another thing, as Dr. Aarti was mentioning, the timing may be variation in the child development. Some child may develop early, another child may develop late, but the sequence should be the same. The sequence is not change. And sequence is change, as we were talking that before, suppose the child starts to even the sitting, even starts crawling or something, it's not normal. Mother will sometimes be happy that my child is able to put this even support on the lower limbs at just 8 months, 10 months, may not be right. So sequence is very important. And suppose if it is a problem is there, then you should note it, that in what way the problem is there. Suppose, as already she has mentioned over here also, that gross motor is 40, DQ, and social is 80. So any comment from you? What will you say? What type of the delayed development? Of course, all the 4 components are delayed. But gross motor and fine motor are more affected. Language is less affected, as Kritika has mentioned, and social is still less affected. So what does it indicate from the development point of view? Any comment?
So it could indicate towards cerebral palsy because these patients.
No, I think we'll not jump for this diagnosis. What type of the delayed development? It's a global?
Global.
Okay,
Yes.
it's a global.
Global
It's all the four affected.
Yes, sir.
But still, they are not of the same degree. Then what do you call it? Or I think before that, I should ask, what is the global delay? What is the exact definition of global delayed development? Because these questions are going to be there for any postgraduate. The one? When will you say it's a global delayed development? Of course, good. More than 2 domains are affected. We say it's a global. Now, suppose global is also not equally affected. Disproportionately, what do you call it?
Dissociation.
It's a dissociation type of the delayed development. That means here it is global delayed development. It is a dissociation type. But suppose some baby develops even suppose walking fast and then even the other. That means is something probably what we were talking of the sequencing. That sequencing in change. Then what do you call it?
Developmental skipping.
Okay.
Skipping.
Yes, I think Dr. Shubham. Skipping or it is a deviation. And that is very important. Here, why we are interested to know deviation. That means some part is skipped or not properly developed, and another is advanced. Advanced development is also not. A mother will be happy. But the clinician, we should know that this is not the right way, and the deviation of the delayed development may be the early sign of cerebral palsy. So I think that's the point for the, I would say, pediatrician or clinician, which we should know. Here, what was my point, that we should know first the development, normal, some principles that you can observe, and then you can decide, is it normal development? With the range even what Dr. Aarti mentioned is, I will say she's concerned, it's right. If you say it is abnormal development, then try to define in what way. It's a global delayed development or even specific, because that gives the exactly that which part of the brain is affected. And that will even help you for further management when you are planning. And suppose if it is global, more than 2 domains, then again you can try to define it is a really dissociation and or even the deviation. Accordingly, that will guide you further that what is the likely problem, etiology, or even something, and even that will help you for plan of the management of the baby for further management. Okay. Any other points which you have noted in the history, what Kritika has mentioned, which probably adversely again affects the development of the baby or even your management? What are other points he had mentioned?
So right-sided weakness.
Okay. Yes, Aarti. What does it indicate? Right-sided weakness he had mentioned. What does it indicate?
Left-sided part of brain is involved, which is showing it is not.
No. What I mean to say, anatomically, what do you call it?
Stroke.
That it indicates hemiparesis.
Hemiparesis.
Right.
Yes.
So that hemiparesis will also becomes one obstacle in your management. Even she said that mother is finding difficulty in changing the diapers. What does it indicate?
Hypertonia, increased tone.
Where tone? It is a very classically, I would say, it indicates you. What type of this cerebral palsy is likely?
Diplegic.
Yeah, diplegic. Because lower limbs are more affected. That is very classical in the preterm baby. Right? And in the preterm baby, this particularly where mother is finding difficulty in changing the diaper or even keeping the lower limbs adducted, That is very classical story. So all these points you can spot it. Even further, very good point that this diplegia, even hemiparesis we have noted. Anything else which you have noted when the Kritika was describing?
So seizures.
Seizures,
Seizure.
absolutely. And you know the seizures multiple times.
Mind.
And therefore, in spite of, I will say, good management, that will become the obstacle in your management. That recur, and therefore well-controlled seizures are very important. Here, I think once mother stop or due to some reason, but recurrence of the seizures, even lower respiratory infections, right? That will also cause the problem. Anti-epileptic drugs, even drugs themselves also, we have to give, but of course it becomes a little bit problems which we should keep in mind. So here, what was my point, that when the Kritika had described the whole developmental history in details, we should note all the issues. So that was the point. I think now before we go further, let us take Dr. Deepika. Would you like to take these points further? To add?
Yes, sir. All right. So Dr. Kritika, good job. Let's, like sir said, everything matters in development. So
Deepika, I
first
think
thing we have to
Deepika, I
know
think can you make your video off so that net issues can be minimized, because your voice is breaking.
All right. Is it better?
Yeah, now better. Now better, please.
All right. Okay. Let's go ahead. Okay. So, like sir said, everything matters in development. So very important, before you know abnormal, we have to know normal, which means all of us should know the normal developmental milestones. And there are 2 or 3 more points in this kid which is important. One, there is a history of squints, which will always affect the balance and coordination. Second, the child responded to sound at 11 months of age. So do we have any reason for that? Although the language, what the child is speaking is not that bad. The social is better, but we still have a speech and language delay because the DPU for speech and language is 55. These we have already discussed. And there is a tightness at the adductors. So his hips being checked, because whenever we are thinking of motor developmental delay, especially diplegia, hips always are very, very important in the development part. So if 2 things, one, the normal developmental milestones have to be known, the chronology has to be known. Like sir said, we have to know whether it is a dissociation or whether it is a deviation. Are we we are skipping milestones, and we have to take care, we have to see about the squint, about why did the child respond to sound at 11 months of age, and what is the hip status.
Thank you very much. Madam, from here, anything, Dr. Seji, would you like to add?
Yes, sir. Actually, already all points discussed. Few suggestions are in history
Yes.
taking. Like the all points covered, but the way the sentences can be modified. Like after developmental history, you can conclude, Kritika, a sentence can be added, the conclusion. Like, so developmental history suggests you of a global delay as suggested, and with motor domain more affected than cognitive or equally affected. So that concluding sentence can be added. That's one. Second, you have mentioned about the diaper change because of the tightness in hip joints. So that in a better way, mother noticed difficulty in changing diapers because of the tightness of thighs, difficulty in separating the thighs apart. So that will be better, conveying an erector spasticity.
Yes.
And the weakness you have mentioned, I think that can be mentioned as paucity of movements or on right side noted, because that conveys something acute happened, the weakness noted. So better in a way, the mother noticed decreased usage of right hand with early left hand preference at the age of 15 months. So all points are right, just in a different way of putting it in the history. And better to avoid a usage of Levipil trade names in history taking, levetiracetam, sodium valproate, so that will be better, Kritika. Otherwise, very nicely put up history.
Acha. Thank you, madam. I think madam added a very good point for all of us, that after this examination, we should go for our inference. For postgraduate, I will say UG, it's all right that he will mention just whatever he has observed. But here, I think as a postgraduate, after an observation, as Madam said very rightly, that after the developmental history, you should put your interpretation. Thus here it's an abnormal development. Then you put as our global delayed development. When it is a dissociation or deviation with even the motor deficit. So I think that becomes an interpretation. That's very important. Yes, I think a very, very valid point which we should keep in mind. Dr. Aarti, Madam, would you like to say something or should we go further? Dr. Aarti, Madam, from BJMC Pune. Anyway, I think she has mentioned this regarding the language. What is language and what is speech? I think we are using interchangeably. Dhaval, both are same or is there any difference? Most of the times routinely we are using that whatever the student likes, speech, language. But is it right or would you like to? Yes, Dr. Rajat, you have some idea? Speech and language?
So speech has actually multiple components. So the output and the comprehension and the fluency of the speech. So
I think if you are not able to give me the definition, no problem. But can you explain me that this is the speech and this is the language or both are same or what will you differentiate these two?
The language will be a meaningful words.
Yes.
Or which child can understand from their own language or anything. Speech will be any random words which are not even meaningful or.
Yeah. As many a times politicians are speaking. Is it? Is it meaningless? Or in the lighter when I'm talking, but you know that I would say caught the very appropriate point. Because many times it happens in the exam that we are not able to, students are not able to clarify it. And they are both are not same. We'll have to understand it. You know, speech usually, somebody will ask that what is the, because Aarti reminded me, how will you define the speech? Please remember, if you go in this way, probably less of the confusions, it will be more clear. The speech is defined the faculty of communicating, expressing and understanding the thoughts and ideas through the medium of some symbols, which is in the form of the written or spoken words. I think this will be somehow I remember the definition of speech since many years. That's why I could even give you, but I think it becomes very clear. Of course, what Aarti said simply, but that is the speech. Here it's a way of communication or understanding or expressing our thoughts or ideas. And that is in the form of some symbols. And these symbols are in the form of the written or spoken words. That is exactly the speech. Language is beyond the speech. You know, some person, I think you must be watching the television news with deaf and dumb. That lady making some signs and explaining us that what she wants to say. She's not speaking. That is also the language. You know, the child who is not able to asking for, I will say, demanding something, but explaining the mother with the signs or some gestures. So, you know, language includes all these things: speech, signs, gestures, right? So many, and all these are the way of communication. So that's the difference. And I think here that we should go, and, you know, sometimes child is able to communicate, but not by exactly these express words, but in some other forms. That also you should go in the details. Many times, you know, for mother it's all right, but once you know in the history that the child is, this is the way of communication for the child, then we understand that, oh, this is something different. So that's a point, even difference you should know. Now here, I think what she has mentioned, I will appreciate one thing, what Dr. Kritika has mention, which even many times I don't observe with most of our common presentations. Any quotient is plain figure. So DQ means 40, 80, 90 like that, not percentage. But most of the students say percentage. I will say, if you remember our school training, any quotient, IQ, 60, 70, 80, not percentage. And I think here we are very rightly mentioned. That's why the examiners will note everything. Now here, anything, can you make the comment? Gross fine motor is 40 DQ. But language and social, language is 55, social is 80. So what is your interpretation?
So global developmental delay predominantly motor than cognitive.
Okay. Social language are affected but less affected. So that is also very, very important. I think another word, this may be I will say for developmental pediatrician or experts, it becomes the very basic, but for us, I think very important for the general pediatricians. And Rajat reminded me one more word. What is the cognition? Frequently we are talking the cognition, but what we mean by the exactly cognition? Arti, what is your understanding of cognition? I think in our daily talking, frequently we are using, particularly in the development. Rajat, do you have any idea what is the cognition?
It's mainly the higher mental function which
Yes. What type of higher mental function? Agreed.
So the knowledge, the understanding of the patient, his intelligence, all of these come under cognition.
Okay, Kritika has gone to some points detail, still more. Many times we take as granted that everybody understands. But as a teacher, I gradually go that little bit, better to understand the exact meaning of that word. This cognition is a very complex functioning of the brain. What happens that suppose something is there, child is here, able to understand, then child is able to go for analysis, even can have the memories also assessed because can remember some past events. And with that reference, you will consider that what is the right or wrong action. And that is as a whole what we say problem solving. So it is in short, multiple complex functions of the brain, which includes even the proper understanding, interpretation, memory, intelligence, action, and problem solving. That whole complex, I will say, function of our brain, we say the cognition. And I think that is very important that when we are assessing the child, many times when I will say later when I'm talking my round, even the cognition of the student can also be, MB student can also be assessed. Because daily in our function, we go for that problem solving. So how much it is developed, even cognition of every student is also different. So what was my idea, that developmental pediatrics as a whole is a little bit complex, somehow which don't give the much importance for our understanding. But I'm sure that with the experts will be, and nowadays, because we face more problems in our daily practice, we should be more aware of all these ideas. Thank you. I think before we go further, anything, Madam Dr. Shiji or Deepika, or should we go further?
Yes, sir, we can proceed.
Okay.
Thanks.
Madam, you'll have to bear with us because I want to go in some, I will say very superficial maybe for you, but students probably it is important to understand.
No, sir. We are also learning.
Thank you. Thank you, Madam.
Yes.
Yes, Kritika, you can go further.
Yes.
I think Shashank has to share.
Continuing with family history, there is no history of consanguinity in parents, no history of seizures, developmental delay, or any similar complaints in any of the family members or the siblings. No history of any sudden sibling death in the family. Next slide. Socioeconomic, the child belongs to a lower middle class family according to the modified Kuppuswamy scale. Immunization history, his vaccination is completed as per the NIS, and last vaccine was given at 18 months of age. However, no documents are available. Next slide. Dietary history. His current calorie intake is 900 kilocalories per day with a deficit of 14%. Protein intake is adequate. Complementary feeding was started at 6 months of age. Currently, child is on solid home foods, and there is normal swallowing with no complaint of choking or regurgitation of feeds during feeding. Next slide. Summary after the history. It's a 3 year, 7 months old male child born to a non-consanguineous marriage with significant birth history and an ICU stay with global developmental delay, which is motor more than mental, with spastic diaplegia, with right hemiparesis, with GTCS type of seizures. So next is the examination. Shall I start with the examination, sir? So should I continue? Sir, am I audible?
Yes, you are audible.
Yeah, as Kritika, please go ahead.
Okay, sir. So coming to general examination, the child was in adequate light with proper aseptic precautions with informed verbal consent of the mother. The child was playful and conscious during examination, and it was done in sitting position. The child was awake and in mother's lap. Next slide, please. Anthropometry. The weight of the child is 12 kgs, which lies between -2 to -3 standard deviations. Height is 93 centimeters, lies just at -2 standard deviation. The weight age is 2 years and the height age is 2.7 years. Head circumference is 46 centimeters, which lies just at -3 standard deviation. Mid-arm circumference is 14 centimeters. Next slide. Coming to vitals, the patient was hemodynamically stable at the time of examination, which with normal vitals, temperature of 98.1 degrees Fahrenheit, heart rate of 98 beats per minute, respiratory rate of 30 breaths per minute, BP of 80 by 50 mm of Hg, and saturation 98% in room air. All peripheral and central pulses were well palpable. Next slide. Coming to general examination, there was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. Head-to-toe examination, the head was normal in shape. The AF closed with normal black hair. The face, the child had no facial dysmorphism, asymmetry, or drooling of saliva. The eyes, there was slight mild right eye esotropia present on examination. There was no telangiectasia, epicanthic folds, or ptosis, no cataract. On examination of the ears, there was no obvious anomaly seen. Next slide. Oral cavity, there was no oral thrush or oral dental caries present. Palate was normal with no cleft palate, no high arched palate. Neck, there was no obvious anomaly seen. Spine was normal. No neurocutaneous markers. Limbs were normal with no polydactyly or syndactyly. Genitalia normal. Next slide.
Shashank, next slide.
Now coming to the systemic CNS examination. At examination, the child was not crying, was conscious and cooperative. Next slide, sir. Starting with cranial nerve examination, the olfactory nerve could not be assessed. Second cranial nerve, the pupils were bilaterally normal in size and reactive to light. Both direct and potential reflex were present. There was squint present, non-paralytic, and there was right eye esotropia, non-paralytic type. The child could identify, name, and match color and objects at a distance of 1 meter standing from him. Fundus examination was normal in both the eyes. Third, fourth, and sixth cranial nerve, the eyeball movements were present in all directions. Fifth cranial nerve, the conjunctival and cordial reflex were present. Next slide, sir. Seventh cranial nerve, there was no facial asymmetry, no drooling of saliva. On examination of eighth nerve, response to name was present and the child could follow sound in all directions directly. Ninth and 10th nerve, no regurgitation of food, no pooling of secretions. The uvula was central in place. Gag reflex was present. 12th cranial nerve, no tongue deviation, fasciculation, or atrophy of the tongue was visualized. Next slide. Motor examination. Posture, child was sitting with adduction at the shoulder joints, flexion at the elbow joints, normal curvature of the spine. There was flexion at the hip joint and the knee joints, with plantar flexion at both the ankle joints. On palpation, there was tender Achilles tightness present. Next slide. The bulk was symmetrical in both the sides. There was no hypertrophy or atrophy of any of the limbs. Next slide.
Next.
Tone. On peripheral tone assessment, there was spasticity present in all the 4 limbs. However, it was more in the lower limbs as compared to upper limb and more in the right lower limb as compared to left. Truncal tone was normal and there was contracture which was dynamic at the right ankle joint present. Superficial reflexes were all normal and present. Next slide. Deep tendon reflexes. The upper limb biceps and supinator jerk were 2+. Bilateral knee jerks were brisk. The right ankle jerk was 4+ with slowness, and the left ankle jerk was 3+. Next slide. Power, sir. This power is more than 3/5 in all the limbs. However, there is definite weakness on the right side. So the power is 3/5 in the right side of the body and 4/5 on the left side of the body. Sensory system, there was response to pain and temperature present. Cerebellar signs and meningeal signs absent. The spine and skull were normal. There were no autonomic signs present. Previous slide, sir. The previous one.
Is this a video?
Shashank video she will play later on.
Okay, sure.
The previous slide one, please. Previous one, previous. Before this. Before, sir, when you're going forward.
I think you are going ahead, but she wants previous slides.
Can I go back?
Yes, back.
Yes.
Back more. Another one.
One more back.
It's not going. Wait. Hold on, sir. It's not going actually. It's a 40 slides.
Okay. I think Kritika, you can. Okay.
Yes. This one, yes. Primitive reflexes were absent and or the gait is abnormal. The patient has a spastic type of jump gait with semi-flexion at the knee, flexion at the hip joint, and plantar flexion and deformity at the ankle joint. And sir, I'll be showing the videos of the gait now.
I think at the end you can.
Okay, sir. So please, next slide, please. Yes. Rest of the systemic examination was normal. On respiratory examination, there were bilaterally normal vesicular breath sounds heard, guided sounds. CVS examination was normal and abdomen was not with no organomegaly. Next slide.
Okay, I think reports you can go at the end.
Yes, sir.
Now I request both the I would say experts. I will have to leave early due to some prior I will say commitment. So can you please go ahead, and you'd have to pardon me. Please apology for that, but I will have to leave in between. Please,
Yes,
madam.
sir. No problem, sir.
Dr. Shiji and Dr. Deepika. And
Yes,
Nehal
sir.
is there.
Sure.
Nehal, I'm
Thank you for
taking the
your help.
permission. Thank you very much.
Yes, sir. The experts are there and they can definitely guide and take over the case.
Yes.
Further. Thank you, sir. Thank you so
Thank
much.
you. Thank you very much.
Thank you, sir.
Thank you. Thank you.
So, Kritika, have you? Yes, Dr. Nehal.
So, ma'am, you can go ahead and discuss with the findings.
Okay. Kritika, can you summarize, or should we remove the screen sharing and discuss?
Yes, ma'am.
As we did before? Yeah.
I'll summarize.
Yes. When you just summarize the case and we'll discuss one by one.
Yes, ma'am. So the patient is a 3 year 7 month male child, second by birth order, who's a product of non-consanguineous marriage, born via cesarean section with significant birth history and NICU with this type of sequence with global developmental delay, which is motor more than mental, right-sided hemiparesis, spasticity of all the forelimbs more than upper limbs, right ankle dynamic contracture. So, ma'am, it's a global developmental delay with spastic diplegia, spastic diplegia type of cerebral palsy, which is right with hemiplegia, hemiparesis, and ma'am with GTCS type of seizures with right eye esotropia and right ankle dynamic contraction. Probably secondary to prematurity or a perinatal insult.
Dr. Kritika, can you ask them to just stop sharing the screen because then you all can discuss better?
Yes, ma'am.
Shashank, can you just stop? Is he sharing the slide?
Sure, ma'am.
Yeah, can you please? Yeah, thank you so much. Yeah.
Yes, Kritika. So you have summarized your case. So when you summarized after your history taking, so there also you have mentioned spastic diplegia with hemiplegia. So it's very difficult if you have two things together. It's very difficult to localize. So what will be the better terminology here? Diplegia, the localization in brain is different. Hemiplegia.
Yes, ma'am.
Any other terminology you can use? The problem here is both lower limb involvement and one upper limb involvement. It's like actually it's a triplegia.
Okay.
Okay. Or it can be a quadri with asymmetry. But here you are saying lower limb is more affected than upper limb. So it's a diplegia with one upper limb more affected. So I think the better terminology can be a triplegia.
Yes, ma'am.
Triplegia. And here, so that can be changed after the summary.
Yes, ma'am. Okay, ma'am.
Second part, yeah, the few things can include if you not much definition can be done in detail. Kritika?
Ma'am, you're not audible, ma'am. Sorry, ma'am, I can't hear you.
Okay. Sorry. So we'll go one by one. So the general examination part was perfect. Head-to-toe examination was perfect. So the purpose of doing this part is to find out any dysmorphia or genetic etiology and this prematurity for the developmental delay. So there was nothing towards that etiology. The nerve system examination. So higher mental functions. So that part can be described in detail. Okay, because this is 3 years and 7 can be detailed. Description can be done, like what is appearance of the child, how the child was so going on, was cooperative for the examination, confidences and interest in toys. So that conveys us two parts, any autistic behavior or any behavioral appearance and behavior part can be conveyed. Then speech can be said in that space.
Yes,
my voice is breaking.
Yes, ma'am, a little.
Okay. Okay, I'll stop my video. Now, is it clear?
Yes, ma'am, it's better.
Okay. So higher mental functions, you can summarize a bit with the appearance, behavior, eye contact, speech and language, bit of attention span. Usually the attention span will be 3 minutes to 5 minutes of their age, usually. So approximate attention span if somebody asks you in exam. With age, attention span changes.
Okay.
Intelligence will be difficult. So that part is actually your cognitive milestones for a 3-year-old child.
Yes, ma'am.
So that is the shape concept, knowing the name. So some of your social development, language development, and few fine motor. I think Dr. Deepika will be knowing better, will be explaining this better. So that can be given in your higher mental functions in the intelligence part.
Okay, ma'am.
The ideal explanation, how to present a higher mental function in a small child.
Yes, ma'am.
Okay, many of the students I have seen, they get confused what to say and what not to say and how to assess each one.
Yes, ma'am.
So that can be concluded. And cranial is fine. So in motor system examination, I think the power examination.
Yes, ma'am.
It was grade 3 on one side you have mentioned. So that's not actually, should not be right. Any child walking independently should have a power of more than 4.
Okay.
Then only they have a power with against mild resistance. So they should be walking independently means it should be 4, not 3. So you have shown it as grade 3 on one side and grade 4 on other side. So please recheck
Yes, ma'am.
it again. Okay. Yeah. The rest of the reflex and all right. So in examination, nothing extra. This part I want to correct. And the contract you have mentioned later, it's dynamic or
Yep.
Fixed. Why it is important to know? Is it dynamic and fixed?
Ma'am, the therapy will depend on the type of contracture. If it's a dynamic contracture, then physiotherapy and drugs and botulinum injection, they are better modalities for treatment for that patient. But if it's a fixed contracture, then these treatments won't be much useful, and that patient would better be treated with a surgery or a tendon release procedure.
Yeah. And next part is Dr. Deepika, you want to include anything here?
No, see, the way it can be done is that you can divide how we are giving the history summarization into 3 parts. First, it will be the growth. This child does at a head circumference less than the 3rd centile. Second can be the neurological assessment. If we have done any specific neurological scale like Hammersmith and all, it makes it easier because it does give a score to us to put it more in perspective. But even otherwise, the neurological assessment, which will include from a developmental perspective, the function, which is the eyes, ears function, the tone patterns, the spasticity, power, everything. And third will be the development part, which will include the milestones. So what are the milestones for gross motor, fine motor, personal, social, speech, cognition, and the DQ for each of them. So that can be compartmentalized into 3: growth, neurological assessment, and the development. That will concise it. And then the part of the reports which were done can be added in it. I think Dr. Shiji, you can take it further.
Yeah. Thank you, Deepika. So one more thing I wanted to add, the grading of spasticity, which you can learn it easily. So there are 2 scales. In infants, you can use the modified Hamilton angle, but your 180-degree flip test can be done to assess the tone. In big children, like this child, which scale can be used to grade the tone? Anyone? Kritika? Any scale used to assess the tone in children. You can assess it clinically. Modified Ashworth scale.
Ashworth scale, yes, ma'am. Ashworth scale.
So modified Ashworth scale can be used. So it will give you perfect idea. Is it more in the lower limb, upper limb, right, left comparison? So there is a number. So it will be more subjective, and you can confidently say, yes, this is grade 2 and this is grade 1. So that scale can be used and you can learn it easily. It is available in books and internet also. So please go through the modified Ashworth scale. Another point is gross motor function scoring.
Yes,
That can be done. Yeah. So to assess the functional status of the child.
Yes,
Okay. So these are the extra points needs to be added in your examination. Rest are perfectly done. So in coming to the summary. So in summary,
ma'am, I added at the end GMFCS2. This child has a GMFCS.
You have added. Very good. Yeah. So when you summarize a case, yes, summarized well. And finally coming to means I usually prefer to put it to different headings, like what is a functional diagnosis here? So this child has got what is a functional disability? There is a developmental delay. So there is a global developmental delay with motor more than cognitive or mental milestones.
Yes.
With examination suggestive of maybe a spastic triplegia. That's a better terminology. Spastic triplegia. Then this is your functional diagnosis associated with epilepsy. In this child, there is seizure.
Yes.
You can give the comorbidity of epilepsy, squint, and contractures, dynamic contractures. With a GM-FCS score of what should be the score here?
Ma'am, this child has a score of GMFCS 2.
So you give the score. So this becomes the functional diagnosis. I hope everyone got it. So
Yes,
the developmental delay, which domain more affected, with your final conclusion like spastic quadriplegia, spastic diplegia, spastic hemiplegia, or dyskinetic CP, dyskinesia. So whatever it is you mention, then associated comorbidities you mention. So that becomes a functional diagnosis. Now what should be your anatomical diagnosis? Means localization, second part.
Yes, ma'am.
In this case, where will you localize?
Ma'am, since this patient has a spastic type of cerebral palsy with the significant birth history, and also he was a preterm baby, so most probably, ma'am, a periventricular lesion, ma'am.
Yeah, so in periventricular, so preterm hypoxia affects the periventricular white matter, which is known as periventricular leukomalacia. That typically causes what type of CP, cerebral palsy?
Spastic, ma'am, spastic diplegia.
Spastic diplegia, so lower limb. So in the periventricular area, the fibers descending from the motor cortex goes along the periventricular white matter. So that's why the lower limb is more affected than upper limb. But here, upper limb is also affected. So what could be the reason? Preterm child?
Yes, ma'am. Ma'am, this child had, it was a twin pregnancy.
Yeah.
And one twin had demised. So
Mhm.
could be that there was an associated infarct or embolic event that led to hemiparesis or weakness of the right upper limb as well. Ma'am, there could be other parts of the brain involved, such as internal capsule.
Okay, so always remember when in a preterm child, especially less than 34 weeks, they are highly prone for other than HIA, preterm HIA, and other possibilities, intraventricular hemorrhage, germinal matrix hemorrhages. So that germinal matrix are situated near the internal capsule, that is a caudothalamic group, the caudate nucleus and the thalamus. So your fibers again going there.
Yes, ma'am.
So bleeding happens there. So that might have caused this abnormal upper limb affection more. Okay, so one possibility is IVH itself in this child. Second possibility, because of the twin death, even intrauterine bleed might have happened.
Yes, ma'am.
Okay, that's the explanation here. So any preterm child, not a diplegia, if child is having a quadri with asymmetry or a triplegia, remember other than PVL, the preterm HIE, along with that a bleeding might have happened. That's how you explain. So that is anatomical localization.
Yes, ma'am.
So periventricular white matter along with the involvement of your caudothalamic area, internal capsule. On which side?
Ma'am, the left side.
Left side, correct. Then this is your anatomical diagnosis, localization. Third, etiological. You
Yes,
know it. So etiology is a preterm prematurity with hypoxia with possible intraventricular hemorrhage.
Yes, ma'am.
Okay, so this is how 3 headings you can give: functional diagnosis, anatomical diagnosis or localization, third, etiological diagnosis. So under 3 these things, you can conclude your case. So any other thing you want to include in this? Anything you have missed? So GM-FCS score already you mentioned. Yeah. Kanika ma'am, any points you need to add, ma'am?
No, I'm all good. You can continue like this, because I would think more in terms of
Development.
the functional rather than
Yes.
anatomical. So yes,
Yes.
it's easier if you go ahead.
Yes. A few questions for the students. What could be the possible reasons of this motor abnormality in cerebral palsy? So here, any type of CP. Here there is a motor abnormality. So what could be the reason? How will you explain that? Reason for motor disabilities. Dr. Dhaval? Kritika?
Ma'am, spasticity.
Yeah.
The spasticity and the contractures which cause disability and hence motor impairment in this patient.
Correct. Only spasticity, anything else? Okay, it's a pyramidal lesion, upper motor neuron. So there will be some form of weakness. So you are not having a grade 5 power. So along with spasticity, mild weakness. Third will be a contracture developing. So that will be affecting. And because of not in this child, any CP with cortical involvement. So they can have an apraxia and cortical sensory impairment. So all these things will contribute to the motor impairment. So if somebody asks you, you should be knowing why there is a motor impairment seen in this cerebral palsy. Okay. And next question, how much common is epilepsy in preterm children? This is a preterm child. So this child has initial a fever-induced seizure followed by unprovoked seizure. So now child is fitting into an epilepsy diagnosis. So what is a percentage or possibility prevalence of epilepsy in cerebral palsy, diplegia? Dr. Aarti, Dr. Dhaval?
Ma'am, 40 to 50%.
Very high. So which type of CP has got maximum possibility of maximum incidence of epilepsy? Which type of CP?
Quadriplegic CP.
Spastic quadriplegic has got the maximum. So it might vary from, I think, 50 to 95%. Depends on the type of damage. If it's a diffuse cystic encephalomalacia, high possibility of epilepsy at an early age. Second possibility is for hemiplegic CP, approximately 25 to 30%. Then comes your diplegic CP. That will be approximately 15 to 25%. And the least is your dyskinetic CP, in which especially the choriothetoid type secondary to your connectors. So the sequence of possibility of having an epilepsy, spastic quadri, followed by hemi, then di, then the dyskinetic group. Okay, so epilepsy, that question should be very clear. Then comes the vision impairment. So vision impairment is more common in preterm babies. Why?
They're more prone to hypoglycemia.
Okay, one possibility, hypoglycemia. Second?
ROP.
Ma'am, ROP due to oxygen.
Yeah, so ROP, very good. One is ROP, yes, they are prone for hypoglycemia. Third, this optic radiation is going along with the periventricular posterior white matter, in which you will have a damage. So occipital radiation is affected, so they can have field effects and refractory errors. So remember, yes, highly prone for refractory errors, all these preterm babies. Even though they don't have any ROP, they don't have any hypoglycemia, there needs to be screened for refractory errors as they grow up. Yeah, so that is visual impairment. Hearing is maximum affected in which type of cerebral palsy?
Choriothetoid dyskinetic.
Very good. Choriothetoid type. That is secondary to kernicterus. Very good. If any type of cerebral palsy, and those who are the high-risk babies who are in an ICU, so there are multiple risk factors for them to have hearing impairment. So all babies have high risk, but maximum possibilities in this spectrum of choriothetoid CP. Okay. Next is how to localize, just to take other cerebral palsies like diplegia, you go to the periventricular white matter. So if it's a spastic quadriplegia, where will you localize? So what all points you need to localize? Spastic, if this case was a spastic quadriplegia. If spastic quadriplegia, it should be a diffuse involvement. Okay, so what all points you want to know if whether child has got epilepsy or not? So any presence of epilepsy indicates some cortical involvement. Okay, if significant early onset seizures, again indicates significant cortical involvement. So how will you localize? It can be cortical and subcortical involvement, which will be diffuse. Okay, so diffuse cystic encephalomalacia is a terminology used by the radiologist. That is usually because of a prolonged asphyxia. Okay, so if you have a severe prolonged asphyxia, so in asphyxia, you have different terminologies. Right, so sudden, some sentinel event, abruptio placenta happen. So what will happen? Acute severe asphyxia. So that will lead to involvement of which part of the brain? Sudden hypoxia happened. So which will be affected? Your highly metabolic areas, your basal ganglia, your thalamus, brainstem, motor cortex. So remember like this. So they have both dystonic component because of the basal ganglia and the spastic component because of the motor cortex involvement. Clear? So very acute sentinel event, something happened, like an abruptio placenta happened, uterine rupture happened. So that will lead to an acute severe asphyxia and affection of the basal ganglia thalamus, which is known as BGT pattern, basal ganglia thalamus pattern. So you localize into the deep nuclei and the cortex. This spectrum will have high possibility of epilepsy, significant developmental delay, severe spasticity, and dystonia. I hope you are getting me.
Yes, ma'am.
Yeah. Next is partial prolonged asphyxia, in which you have a cord around neck, and as child descends, cord is getting tightened around the neck. So there is a partial prolonged asphyxia. So which part will be affected in brain? The brain has some time to save the main areas of basal ganglia and the brainstem.
Subcortical region.
Yeah, subcortical region, which part? So in such situation, your watershed areas comes. Watershed areas means the junction between two different arterial territories. Right. So AC and MCA territory usually comes at the parasagittal area. You know the sagittal suture. So just lateral to it, your junction of AC and MCA comes. So there will be affected. So that is parasagittal injury, because this is bit in depth to localize, to have an idea the type of asphyxia and type of the brain injury and type of CP in them. Okay, so this parasagittal injury will lead to a quadriplegic CP without dystonia associated. Here cortical involvement and subcortical involvement will happen. Again, epilepsy is very common in this. Clear? Third group is severe prolonged, the continuous prolonged asphyxia, obstructed labor, prolonged time child is stuck. So severe prolonged will cause diffuse brain involvement. So that will lead to a cheesy brain later. So entire brain cortex is affected, usually the deep nuclei and the brainstem spared. So they have a diffuse cystic encephalomalacia, and that lead to again spastic quadriplegia. Clear?
Yes.
So different type of asphyxia. And preterm children,
Spastic.
diplegia, and localization is your periventricular white matter. And another group is your kernicterus, in which part of basal ganglia is affected in kernicterus? Severe jaundice. Your globus pallidus. Globus pallidus. And in hypoxia, it is a putamen. Remember this. Okay, so globus pallidus is affected in your kernicterus. And that will lead to a choreothetoid form of cerebral palsy. They can have even dystonia as well. So they are classified under dyskinetic cerebral palsy. So you got different etiologies, the localization, and the type of cerebral palsy. Please remember this, and the associated comorbidities and the frequency of comorbidities depending on the type of cerebral palsy.
Yes, ma'am.
I think now further, how will you investigate this child and manage this child?
Ma'am, we perform basic workup routine workup of vision, hearing, thyroid. Look for micronutrient deficiency.
I cannot hear you.
Kritika, you have to turn one. You are logged in two, I think. Turn off one. It's echoing.
Okay, ma'am. Ma'am, am I audible now?
Yes.
Ma'am, we'll perform a hearing and visual assessment. Then ma'am, a thyroid profile. Ma'am, we'll look for micronutrient deficiencies. If any, then we'll go for investigation specific to those. And then ma'am, neuroimaging should be performed.
When you will do neuroimaging, actually, ideally all children with cerebral palsy should undergo neuroimaging. What is the guideline?
Ma'am, if there are features of phased ICT or ma'am, if there are other features involved, suggestive of meningitis or
No, this child, you are not suspecting meningitis at this moment, no?
if there is worsening or appearing of new seizures or worsening of the condition than previously.
And regression of milestones.
Okay. So if you're clear about the etiology or any imaging done at birth, yes, fine. No further repeat imaging needed. And in this child, there are multiple risk factors as we discussed, as Sir told. Starting from the antenatal history, there are multiple risk factors. Twin gestation, one child died, preterm delivery, SGA, LBW, birth asphyxia, sepsis, jaundice, so many risk factors. So that's enough. That has caused this abnormality, the cerebral palsy. So ideally not indicated, but if this child is getting a refractory epilepsy, the seizure has started, agree, that is expected. But if child is going into a preterm child having a refractory epilepsy is not right. Okay, so in that sense, yes. If child is getting a regression of milestones, yes. Any other indication? So if you are not sure of the etiology, then definitely you have to do it. So if you have a clear evidence of an ICU admission, documented an ICU discharge card, and everything is clear of an birth asphyxia and all risk factors, ideally not indicated unless there is a regression happening later, refractory epilepsy happening later, or new findings appearing later. So that's ideal guideline by American Academy of Pediatrics. So EEG, whether it is indicated here. EEG needs to be done or not?
No, ma'am.
Not needed.
No.
Why?
And if there are seizures present, then we will we'll perform an EEG. We'll have to document one EEG.
Definitely, because here it is now. So what is the definition of epilepsy? Whether this child has got fever-induced seizures or child has epilepsy. How will you defend yourself? It is epilepsy or febrile seizures?
And the first episode of seizure that occurred was preceded by fever. However, the following two episodes, they were not associated with fever. There was no any trauma or any neurological insult, acute insult at that time. So, ma'am, yes, this patient, those two episodes, ma'am, I mean, it can be considered as epilepsy.
Yeah, I think later on 2 unprovoked seizures further happened, right?
Yes.
Other than the first. So the definition of epilepsy is 2 or more unprovoked seizures more than 24 hours apart, right? So this child has got so many factors in the background: abnormal neurological examination, abnormal development, plus unprovoked seizures more than 2. So multiple seizures. So that definitely indicate child has got epilepsy. So in epilepsy children, if child is not evaluated before, this child actually already evaluated and done. So no need of doing it again. But if child is coming to you without any treatment, yes, you should be doing EEG. Why? Actually, the newest ILA definition for epilepsy, the type of seizure is classified based on EEG finding. Even though you see it as GTCS, the onset may be a focal. So the onset might not have been witnessed by the parents. It might start at the one side, or a deviation of angle of mouth is enough to classify it as focal. So EEG is important to classify the type of seizure also, and to decide about the treatment also if it is abnormal. And sometimes 20 to 25% can have normal EEG also. So doesn't mean that we should not treat it. So EEG, yes, should be done. Hearing evaluation, yes. Vision, yes. Look for refractory errors as well. MRI, okay. Depends. So this child, I won't do it now. I'm very clear actually, but already done and showing the hemorrhage. Yeah. Then.
What about the hip joint? The hip joint also will have to be evaluated for this child. He is having a diplegic CP going on. So here it becomes important, not now for the long-term progress. Hello? Can you hear me?
Yes. Please continue.
So hip evaluation. See, whenever we are doing any investigations in a case of developmental delay investigations are always 2. 1 to find the etiology, 1 to find what is happening inside the brain, in which we have the MRI. But 1 is more for the functional improvement of the child. So for functional improvement, it is always thyroid, eyes, ears, and hip joint. And other nutritional deficiencies also need to be looked for in this child. We have to look for B12, vitamin D, because all of that are going to make a difference in the developmental profile of the child. All right, ma'am. Take over.
Yeah, thank you. Thank you, Dr. Deepika. Now, this is the investigation. Now, how will you manage this child?
Ma'am, it has to be a holistic approach. We have to first of all involve the parents, the people who are living with the child, the school teachers, all have to be involved. And we'll start with physiotherapy, ma'am, occupational therapy. And we have to focus on making the child age appropriate. His milestones should be age appropriate. And we should be able to make the child independent, functional independent. And so we'll start with physiotherapy for the spasticity and the contractures. Since it's a dynamic contracture, we can also look into drugs which to reduce spasticity and botulinum injection. And then occupational therapy to improve his functioning. And ma'am, speech and language, since they are also delayed. Ma'am, also we can look into arthrosis for contractures. And
to address each factor, like first is your child has got some weakness and spasticity. So how to manage that? To start physiotherapy, stretching exercises, and that is to decrease the spasticity, and strengthening exercise to improve the weakness, improve the muscle strength. Okay, so that is physiotherapy. Second part is contracture. So in contracture, to prevent the progression of contracture, you should be using orthosis. So in this child, you have a tendo-Achilles contracture, and in diplegic children, they are more prone for hamstring contracture as well. So there will be a crouching. Child will bend at the knee when they have a hamstring contracture. So what type of orthosis you will give? Initial one should be angle foot orthosis. And in this child, we can have a hinged orthosis. The child can dorsiflex well with a hinged orthosis.
Yes.
And the positioning of knee as well, with extension at the knee, and a above knee orthosis can be given if contracture of hamstring develops. So that is orthosis part. So any role of botulinum toxin in this child, what do you think?
Yes, ma'am. He is a good candidate for botulinum toxin injection, since it's a dynamic contracture and it will act locally and not cause systemic effects. So that's a good option for this child.
Yeah, but it is always remember it's temporary. It might go away after 3 to 6 months, and you have to repeat it again. Another part is your upper limb function. So right side is weak. So we have to focus on that as well, other than lower limb. So the stimulation of right upper limb with a restrainment therapy.
Yes, ma'am.
Okay, so that is part of physiotherapy. Occupational therapy is again for the fine motor functions. Okay, so you should be knowing why you are advising occupational therapy in a child with cerebral palsy. That is to improve the fine motor skills. Okay, speech therapy, if child already started speaking well, so speech stimulation can be done. Yes. And treatment of management of epilepsy with anti-seizure. So now the anti-epileptic drug AED has been changed to ASM, anti-seizure medications. So you can use that when you're present. Okay, so anti-seizure medication optimization, which is already done. Anything else you want to add? Nutrition
supplements, and he's consuming adequate, just a 14% deficit in calories. So the intake, his weight is between -2 to -3 standard deviation. So we could always ask them to increase the calorie intake, to add energy dense foods if he's unable to take large quantities, and add supplements.
Yes. So in other forms, so if you have a quadriplegic cerebral palsy, they can have the drooling of saliva. So they have a oromotor dysfunction, pseudobulbar palsy type of picture with continuous drooling, difficulty in chewing, swallowing. So that part should be addressed in them. But in your physiotherapy and occupational therapy and speech pathologist, all will act together for that. So remember that aspect, because in this child, nothing there. So fine. But other cases of cerebral palsy, you can describe that part also, taking care of nutrition, feeding issues, dental hygiene and dental caries, other than spasticity, contracture management.
Yes, ma'am.
Very nice presentation, Dr. Kritika.
Thank you, ma'am. Thank you so much.
Dr. Nehal, I think.
Yes. So I was there throughout the discussion, and really Kritika has prepared very nicely. And the presentation also, I must comment, that she prepared the presentation so nicely with all the videos, with the pedigree chart, and
Yes.
with some pictures also for the systemic examination and pointers.
Yes,
So
yes, it's very nicely made.
beautiful presentation. Actually,
Yes.
all the PGs also who are presenting on these e-platforms, there are multiple e-platforms by our IAP. So they should also know this type of presentation, how to make it so interesting.
Yeah.
So it's very nice, Kritika. Well done. And I must thank her mentor that she prepared her so well.
Yes, yes, yes.
I also thank the students who are participating in the discussion. Still, there are many students who are attending but not vocal. So students, this is a platform where you can discuss, and there is nothing to speak if you are not sure about whether it is right or wrong. You can always speak some things, whatever comes in your mind. And we are having a healthy discussion, and the experts are there to guide us. So please be vocal, take part in the discussion. And thank you so much for both the experts, Dr. Deepika, for guiding us through the milestones and giving some wherever required your expert inputs. And Dr. Shiji ma'am for taking the case, and actually when the Baldevs are left and you take over the case, and it was guided very nicely. Shruti ma'am, thank you so much for providing the student. So thank you all.
Yeah. Thank you. Thank you, ma'am.
We have the
Thank you.
certificates for the presenter and experts and the mentor, and I will share personally.
Ma'am, if you want, I do have like 3 certificates in front of me. If you want, I can go ahead and
Yep.
share this.
Share, please share.
Sure. Thank you.
Thank you so much. Thank you, everyone.
Yes. So thank you, Kritika, for being the presenter.
Thank you
And
so
please motivate your other friends. No, this is for Sayan. It was last time's this. Anyway, I will share them personally, all the certificates.
Sure, ma'am. Actually, I just received this free, so I just shared
Okay.
what I
I will.
have.
Yeah. Thank
Okay,
you so much.
sure, ma'am. Ma'am, thank you so much, ma'am. Thank you for extending us the opportunity to host a session. And I hope that you had a seamless experience. With all due permission, I'm closing the session today. Looking forward to host you again.
Yeah. Thank you. Thank you, Clarinet, and thank you, Shashank.
Thank you, ma'am.
All right.